Thanks, Dan.
All right, no problems. Okay, so today I was just hoping to provide an overview of low flow anesthesia. And when I started my training, it wasn't until probably about second year when I was introduced to the topic. And I did notice that it was being used widely, probably because the choice of inhalational anesthetic agents limited our use of low flow anesthesia. But as its name implies, it's using fresh gas flow rates that are quite low, much less than minute ventilation. So minute ventilation being tidal volume by respiratory rate, so much less than 5 or 6 litres per minute. This implies that there will be significant rebreathing, so a circuit that allows for rebreathing must be used. And it's as you decrease your fresh gas flow rates, the portion that you're rebreathing will increase, and the excess amount of gas that's vented out of the circuit or scavenge is also decreased. I was looking for definitions, and there's no universal definition, but the most commonly used ones these days for low flow anesthesia is a fresh gas flow rate that's down to 1 litre per minute. Minimum flow anesthesia is when the fresh gas flow rate is reduced to 500 mils per minute. There's also a technique known as closed system anesthesia. I won't spend too much time on that because it's not actually practiced to a great extent in Australia. It's basically when the anaesthetist targets the fresh gas flow rate just to match the patient's uptake. So it's very strict fresh gas flow replacement. We can't use it that much here because our side port aspiration is about 200 mils per minute, and that's not actually returned back into the circuit. So every minute 200 mils is being sucked out, being analysed, and then scavenged out into the atmosphere. The reason why we don't return it back into the circuit is because not all of that aspirated gas is filtered. So certainly when we're connected to a circuit, it's attached to the back end of the filter, but occasionally we attach a nasal prong device to it, or just attach the side port aspirate to a Hudson mask, which is not filtered, and we shouldn't return that to a circuit which another person can then inhale. So just to represent what I've just defined in terms of a graph, you can see that the patient's uptake, so the white portion represents the oxygen uptake, which is a basal rate of around 200 to 250 mils per minute. Just for an example, this is the isoflurane uptake. As you can see, it sort of plateaus around the 5 to 10 minute mark. If you're using nitrous oxide, it does take quite a bit of time, maybe up to 15 minutes or so before it plateaus up. So there is a high wash-in effect for the nitrous oxide. The green line represents low flow anesthesia. So you're providing high fresh gas flow rates initially, and then you can plateau off to 1 litre per minute. This is the minimum flow anesthesia. And then, as I mentioned, for closed system anesthesia, which is used in other countries, you're constantly adjusting it just so the patient uptakes it, as the patient uptakes the gas. So a little bit of history. It was first introduced in 1952 by Folds, who was trying to describe a technique using nitrous and oxygen mixtures. And in the absence of oxygen monitoring, he was trying to determine the concentrations that you would need to provide a safe anesthesia. He noticed that with a fresh gas flow rate of about 1 litre per minute, the oxygen concentration would have to be biased because the patient constantly needs about 200 to 250 mils per minute of oxygen. And as you decrease your flow rates, the amount of nitrous that you're delivering would decrease, which makes sense because you're not taking up too much nitrous after about 15 minutes of the case. In 1974, Virtue introduced another technique, reducing fresh gas flow rates down to 500 mils per minute. And he noticed that there was a marked disparity between the concentration of oxygen within the circuit and that delivered, so the concentrations that you have dialed up. And this is because with such low flow rates, there is a lot of rebreathing going on, so most of it is the expired air that you are breathing. He also noted that it was quite economical using minimal flow rates, but this was also already noted in Folds' technique. So it's their definitions that exist today. So what do you need to start your fresh minimum flow anesthesia? You need an anaesthetist who's trained and experienced in the low flow rates, and you need someone to teach you how to administer it, and then what to do for troubleshooting as well. Now, the equipment that we have that's a standard in Australia is already available for low flow anesthesia, and the main features of the anesthetic machine should include that the flow meters are calibrated down to about 50 mils per minute each increment. The circuit basically needs to be leak-free or pretty much gas-tight. You need gas monitoring, that's quite indispensable in low-flow anesthesia, and your CO2 absorber, since minimal gas is vented. The main advantage that I'll point out is that it's quite cost efficient. As you know, volatiles aren't very cheap. They make up most of our budget. Last month alone, we spent probably just under $20,000 on sevoflurane in the hospital, and just under $7,000 for desflurane. So it's about 74 cents per mil for the sevoflurane and about 96 cents for desflurane. The more you decrease your fresh gas flow rates, the more you would save. And you'd save more if the duration of the procedure is longer, if the price of the anesthetic is agent, so desflurane compared to sevoflurane. And if you do more long cases, you would tend to save more as well, because you save most of it from the maintenance part of the anesthesia. I could only find figures in euros, but as you can imagine, this is what you would save if you compared it to high flow rates. The definition of the source of from the source that I used, high flow rates were around 4 to 4.5 litres per minute. I'm sure no one uses that high flow rates during the case as maintenance anyway, but you can get an idea of how much you can save. So for a 2-hour case with minimal flow rates, desflurane, you just save under 40 euros or 60 Australian dollars, compared to how much you would save with 1 hour case. So you'd save a lot more if the case goes for longer. The yellow bar is sevoflurane and the orange bar is enflurane. This is how much a typical anesthetic would cost for 2 hours. This is the high flow, so 4.5 litres per minute using nitrous oxide. Minimum flow, and without nitrous oxide with minimum flow here. And as I mentioned, the closed system anesthesia. So there is a significant portion that you can save. As you can imagine, 2 litres per minute that I've seen a lot of maintenance flow rates would probably sit around here.
How come these flow rate costs more than zero on this ground?
Sorry, well,
Is it the best flow rate is more costly, isn't it?
I think these are European figures, so it is more, but more people would probably use desflurane at lower rates even, but these are still following the definitions of 500 and 1 litre. So it's probably a European budget. Okay, so another advantage is, as we know, the modern anesthetics that we use are not metabolized to a great extent in the body. Most of it is just exhaled and then vented out into the atmosphere. We never see it again. This is a new term, it's the efficiency coefficient, so how much is actually taken up by the patient to maintain anesthesia versus the amount delivered into the breathing system. So you can come up with a figure that's less than 1 basically. So sevoflurane and desflurane are ideal for these techniques, given that they have low solubility, low uptake, but they're comparatively low in their potency, so you have to deliver quite a bit into the circuit compared to the older inhalational agents. So as you can see, if you're using high flows, you're not getting the most out of your desflurane, whereas if you're using a closed system, it's much more efficient use of desflurane. This is not so much an advantage anymore, given that we use those HME filters universally now. But as you can imagine, rebreathing allows for the heat and the moisture to be retained every time you rebreathe your last breath. So that's one advantage. If you breathe high flows, you're prone to ciliary dysfunction as well as mucosal damage after a couple of hours. Saving the environment, that's another advantage of minimal and low flow anesthesia. As I've already mentioned, it's not really metabolized, it's all just exhaled again and vented out into the atmosphere. Halothane as well as enflurane and isoflurane, they all contain chlorine, and that gets liberated when it's out in the atmosphere and leads to ozone depletion. Those modern anesthetic agents have a lifespan of about 3 to 6 years in the atmosphere. Unfortunately, nitrous oxide is quite a stable molecule, it lasts for about 150 years. and it itself is a catalyst in ozone depletion. With desflurane and sevoflurane, they don't contain any chlorine and appear to have no greenhouse gas effects at all. Overall, compared to the industries and agriculture, we don't contribute to a great extent to global greenhouse gases. But every little bit helps. The other advantage is that you need to understand the uptake and pharmacokinetics of inhalational agents, as well as the breathing system, so that we can teach other trainees about low flow and minimal flow anesthesia. With your advantages, it always comes the disadvantages. Initially, the setup costs may prevent poorer countries from starting this technique. Fortunately, that's already a standard in most of the developed countries, including ours. There are limitations of our vaporizers. For example, when you're maintaining a low flow anesthesia, your vaporizer, your sevoflurane vaporizer may be set at about 5% with a flow of 1 litre per minute, just to maintain that the desired MEK of about 1 or 1.1. If you need to increase the depth of anesthesia rapidly, you can't just turn up to 8 and expect a rapid increase in the agent delivery, because your fresh gas flow rate is still quite low. So one of the solutions is basically to increase your fresh gas flow rate momentarily for about 5 minutes or so, and then decrease it again. A more ingenious method would be to directly inject volatile into the circuit, which can be quite dangerous. I've seen photos of anaesthetists with a syringe of volatile injecting straight into the circuit. So it's not very calculated, but there are machines, modern machines, such as the Draeger Zeus and the PhysioFlex, which have adopted this technique. The GE machines that we have, none of their machines do that. So our machines actually increase the fresh gas flow rate to wash in more volatile. Yep. So lightning can only be fixed by increasing your fresh gas flow rate. So if you need to wash out your volatile, the only way is basically to increase your flow rates, and unavoidably you'll lose some of the gas and it's vented out into the atmosphere. Given that we've got so low flow rates, the time constants are considerably long, so at 10 minutes before the end of the case, you'd probably be turning off your vaporizer at that point. There are other disadvantages, including accumulation of gases in the breathing system, some of them which aren't analysed by our standard gas analysis. Some of the contaminants include carbon monoxide, nitric oxide, argon and nitrogen. Argon and nitrogen are particularly noted because they can't be analysed by infrared technology, given that it contains only one atom in the molecule. So nitrogen can be a problem, especially since it's in the air, and there has been inefficient denitrogenase process during pre-oxygenation, so you have to be mindful of that fact. Other substances can be exhaled by the patient, so your intoxicated patients with alcohol or smoke inhalation, or those that are ketotic. Methane is actually produced in our gastrointestinal system due to the presence of certain bacteria. Of interesting note, methane actually absorbs the same wavelength as halothane, so you may get abnormal recordings indicating halothane in the circuit because it absorbs it 10 times greater than halothane does. I'll spend a bit of time talking about the products that are produced when our inhalational anesthetics react with absorbents, because that's probably the greatest concern that you guys have, and limiting our use of low flow and minimal flow anesthesia. We know that carbon monoxide can be produced when desflurane runs through a dry bariline CO2 absorber, and also compound A, which we've all read about in our textbooks in our primary pharmacology exam. So that compound A is from a breakdown of sevoflurane when it reacts with soda lime. It has a theoretical risk of producing renal toxicity, proven in rats, but our renal physiology is quite different to rat physiology, and there's considerable margin of safety in humans. There's been no evidence of renal impairment, even in patients that have pre-existing abnormal urea or creatinines, and when low flow or minimal flow techniques are applied. But because of this, in the US, they had limited their fresh gas flow rates with sevoflurane to 2 litres per minute. This was later revised in 1997 to 1 litre per minute for 2 MEK hours. This protocol has been adopted by Switzerland and Israel. Us and the Canadians, we still limit ours to, or ours is recommended to 2 litres per minute. Greece, Norway, New Zealand have no limitations. They've abandoned theirs. And in the UK, there was never a restriction at all. Okay, everything has a formula these days. So to understand a bit more about gas uptake in the initial phases of anesthesia, Brody's formula calculates how much oxygen a person requires. So someone of my size probably requires less than 200 mils per minute of oxygen. For the uptake of nitrous, it's dependent on your time. So it's an inverse proportion to the exponential of time. And those formulas the uptake of anesthesia. So it's a constant multiplied by the depth of anesthesia that you require, multiplied by the coefficient of the blood gas coefficient, cardiac output, and again, inverse time. Okay, I'll represent it in a graph for you again. So oxygen is fairly constant, basal metabolic rate. This is isoflurane again, and nitrous oxide. And this is your uptake of your volatiles. It tends to plateau at about the 10-minute mark. Okay, no technique is universal, so this is just a suggested technique from the source that I was reading. They suggested just the usual pre-medication and the induction of anesthesia. Initially, you still need to wash in all your volatiles for the first 10 minutes or so. So they suggested using 4 litres per minute of your desired oxygen concentration, setting your sevoflurane at about 3 to 3.5% or your desflurane vaporizer at about 6%. And then you can reduce your flow rates down if you're using minimal flows, down to 500 mils per minute, setting your sevoflurane at a higher concentration, say about 5%, or your desflurane to about 8%. Remembering that because you've got less flow, you're carrying less volatile into the circuit. In terms of the emergence and the recovery phase, like I said, because of the long time constants, given that we've got low flow rates, you have to turn your vaporizer off quite early. You can maintain your fresh gas flow rates at a minimal rate. And then when you're just ready to extubate, you can wash it out, almost like the purge function on our ACES machines. So to rapidly increase or decrease your anesthetic depth, you can set the vaporizer to the desired depth that you'd like, increase the fresh gas flow rates to about 4 litres per minute, and you need to maintain that for about 5 minutes or so, and then hopefully a new equilibrium is reached. If you're lightening, you just set your vaporizer a little bit lower, say 1 to 2% lower. Or you can just deepen with the remaining propofol that you have, or the opiates that you have as well. I think the easiest way now that we have this new machine is to use end-tidal control, and hopefully everyone's had a go at using end-tidal control. Basically, it's a new algorithm in the module, and every 3 minutes it takes a sample of the gas that's analysed and calibrates the delivery of the inhalational agent as well as oxygen to provide the desired depth of anesthesia. And the easy thing about it is that it has hypoxic protection, which means it will calculate and deliver the right amount of oxygen required for your patient. So you know that you're not delivering a hypoxic mixture when you're running low flows, because it's analysing how much oxygen is actually coming out of the patient. The other ideal feature is, as I mentioned, it has a purge function at the end, so that you can wash out your volatiles very quickly at the end. There's always contraindications to a technique. Patient factors that I can think of is basically those that are intoxicated, so with alcohol, with gas, and with smoke. You could still probably use minimal or low flow, but you have to be fairly vigilant about your gas analysis. Every so often you may want to replenish the breathing circuit's gases. So say every hour or every 2 hours you may want to increase your fresh gas flow rates and just replace what's in the circuit. You couldn't really use it in your malignant hypothermics because one, there's the volatile, and the other thing is they've got a high oxygen requirement, and you'd exhaust your CO2 absorber pretty quickly, which is another negative effect of low or minimal flow anesthesia. And that's because less carbon dioxide is being vented and you're relying more on your carbon dioxide absorber. The equipment factors that I can think of is basically if you're not using a rebreathing circuit, so you really need one of those so that you can use minimal or low flow anesthesia. As I mentioned, the gas monitoring is indispensable. You really need it so that you know how much oxygen you're delivering, as well as making sure that the patient is deep enough. If you've got a significant leak in your circuit, then you will notice that you will have to increase your fresh gas flow rates, or you check your leak. There are some surgical procedures that this is not ideal for, such as your rigid bronch, where you've got a basically open system, and cases that are performed with a face mask, unless your medical student's really good at holding the mask down for you. Does anyone have any questions before I sort of move on? This is basically the end of the presentation, but since we have some time, I've got some photos that I can show to you from Hong Kong.